the tricyclic antidepressant binds tighter to the sodium channel when the pH drops.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are excited to be sitting down and speaking with Dr. Josh Nogar today on the management of tricyclic antidepressant intentional ingestions. Josh, please introduce yourself. Tell us a couple things about you, including something you enjoy outside of medicine.
Thank you very much to both of you for having me here. My name is Josh Nogar. I'm the Division Chief of Medical Toxicology here at Northwell Health and the Fellowship Director of the Medical Toxicology program here. I've been here since 2011. I was raised in New Mexico, and then I went to college in Iowa and NYU for med school, eventually Albuquerque for my emergency medicine residency, and then my Med Tox Fellowship at the University of California, San Diego. I graduated in 2011, and honestly, Northwell Health has been my first job out of fellowship, and I sort of quickly became the assistant fellowship director, and then a few years later, I became the fellowship director. And over that time, we've sort of grown the fellowship from being one that was local within a couple hospitals at Northwell Health to one that's now we cover like the entire Northwell Health system. So for those of you that don't know, Northwell Health has now become like a 28 hospital system here in the New York, Connecticut area. And we provide a virtual consult service for all those Northwell sites, as well as a bedside experience at our children's hospital, which is Cohen Children's Medical Center, and our two major tertiary sites, which is Hofstra University Hospital and Long Island Jewish Medical Center. So we're busy. It's a busy service. We have 8 core faculty. We have 4 toxicology fellows, 2 seniors, 2 juniors. And, we're ever changing, adapting to what people are overdosing on. There are med errors that occur commonly. And so toxicology is still my passion. Emergency medicine is also something that I do. I mean, it's 70% of my job still. That's me professionally. And then I guess outside of work, well, my children are still young, so I spend most of my time taking them to hockey practice. But every now and again, I'll get out for some fly fishing. And that's me in a nutshell.
Well, that's wonderful. And I appreciate the shout out because you're right that while I've consulted you from Cohen Children's, I haven't thought about what it means to do tox for the whole health system. That's a lot of work.
And we're proud of the fact that we've grown that way because it's a necessary service. And I think that overdoses happen at every hospital. And, we're not trying to take away from poison center volume, but this is how we do toxicology at Northwell Health. So it's definitely a busy service.
Absolutely. It sounds like, and correct me if I'm wrong, you're 30% tox, 70% EM. I'm wondering first what the fellowship in medical toxicology looks like. It sounds like maybe it's a 2-year fellowship.
Yes.
And then what do people end up practicing when they graduate? Do they get a little FTE for toxicology? Are they just like a really valuable EM physician? What's the scope here?
That is a very good question. So the 3 of us are in academia, and we all know that protected time is harder and harder to come by. And I think that you've asked one of the most salient questions for all of us that work in academia, which is how do we find time to teach? I'll row back a little bit more. So medical toxicology is a 2-year fellowship training program, and it draws primarily from emergency medicine. However, it is open to people who have internal medicine backgrounds, people with pediatrics backgrounds, so even occasionally preventative medicine. But I think that one of the things that I tell people who interview for this training program is this is not a procedure-based specialty. We're not an admitting service. So we're a lot like infectious disease in that you're asking for a management question to be answered. You have a specific, what should we be doing? And what that basically boils down to is you're sort of this knowledge-based specialty that's trying to provide advice. And the reality is that means you don't make a lot of money. We're not billing out the ear for giving advice. And I think that's why a lot of toxicologists practice at poison centers where you can get a little bit of extra cushion of your salary from a poison center. But even then, it's not that much. So I think this paradigm of the poison center-based toxicology is shifting a little bit because there's like 50 some odd poison centers across the country, and they don't employ that many toxicologists. A lot of toxicologists are university-based emergency medicine doctors who primarily work in the emergency department. And so how do we make our emergency department chairs, how do we convince them that they should protect our time to do this? Typically, it's not a matter of telling them, oh, we're seeing so many people. It's sort of showing value in what we do, patient outcomes, reducing length of stay. All that tends to add up. Most people are pretty happy with the consult service and what we provide, but I think this is the reality of the medico-economics of where we're at right now is justifying protected time. It's different for every place that you go. And here at Northwell Health, we're fortunate. We have leadership that values us and enables us to run a consult service and help the people who are overdosed at every site.
I think all it takes is being at the bedside of one child dying in front of you from a toxic ingestion to realize how valuable a toxicologist is.
For all of our subspecialists, right? You just run into that one patient, whether it's, it's like rheumatologists, right? It's like an outpatient specialty, but every now and then, you have a kid with lupus or RA, and you're like, I really could use some help here. You know what I mean? And it can have this big impact on an outcome. It's not always about, I have a procedure that needs to be done. It's sort of like, I have a question and I don't know the answer to it.
Yeah. Oh, that's huge. Well, before we jump into the case, do you have any conflicts of interest to disclose related to today's topic?
I wish I did, but I do not.
Well, Alice, stay on the call and give us the case.
All right. So we're going to give you a PICU transport call about a 14-year-old girl with chronic pain who presents after an ingestion of an unknown quantity of her amitriptyline tablets. She's a heart rate of 140, a blood pressure of 90/40, and a temperature of 102. Her pupils are dilated and her skin is flushed, and she's actually not currently on telemetry. So we have a few follow-up questions for the outside hospital, but before we get into all of this, how do tricyclic antidepressants work?
So first and foremost, they are as billed. They are antidepressants, and most antidepressants, they improve mood by increasing circulating quantities of norepinephrine and serotonin in the brain. And that has multiple effects, increasing well-being, anxiolysis, and even can create analgesic effects, which is why this class of medication is not only used for the treatment and management of depression, but it can also be used for the treatment of neuropathic pain. So they are great medications for improving the symptoms of depression. But what I teach my toxicology fellows when we talk about psychiatric medications is that within psychopharmacology, if a drug is really effective for treating a certain condition, it's probably kind of toxic too. It has what we would call a narrow therapeutic index. And I would characterize TCAs that way. So they work great for managing depression, but they're what we would call a dirty drug. And the reason toxicologists like talking about them is because they don't just increase brain concentrations of norepinephrine and serotonin. They hit on a lot of other receptors. So from a pharmacologic standpoint, they're a great case study example medication to sort of open up a discussion like this to manage these overdose effects.
So you mentioned the favorable effects of these medications at appropriate dosing is increasing serotonin and norepinephrine levels in the brain, promote good mood. In the context of toxic ingestion, how might their pathophysiology develop with other receptors being worked on?
Well, it's always a balance, right? Especially if patients are on other psychiatric medications. So if they're on serotonin reuptake inhibitors that are also increasing circulating levels of serotonin, it can predispose someone to serotonin syndrome. And anything that increases catecholamines over a certain level can lead to agitation, can lead to seizures, things like that. So usually seizures are somewhat of an end effect of overdose. And that's a good segue into sort of what else happens when you get exposed to too much tricyclic antidepressant. There are a lot of other side effects of these medications. They block a lot of other receptors in the body. So they block muscarinic receptors. So for the med school review of what muscarinic receptors do, and if you antagonize them, you get the classic anticholinergic, or what we would specifically say antimuscarinic effects, which are dry mouth, tachycardia, urinary retention, You can even see delirium. We say antimuscarinic delirium. But tachycardia is a very common finding after a tricyclic overdose. They're antihistaminic, okay? So you can see that typical sedation that occurs, right? You take a tablet of Benadryl, diphenhydramine, you get a little sleepy. They are alpha blockers, and the manifestation of that would be hypotension. They also, the critical pathophys relevant to this discussion is that they are sodium channel blockers. So those manifest as QRS prolongation on an EKG, arrhythmias, which can exacerbate that hypotension, right? You can get a non-perfusing arrhythmia on top of alpha blockade, and you get pulselessness real quickly. They block GABA receptors, which result in seizures. So that from, I've just listed, multiple different effects of TCAs. They can even block potassium channels, and that can prolong your QTC. So that's why we like talking about them. That just goes, the list it's a long list of potential side effects.
Yes. Let me read this back to you. You tell me if I've got it right. Okay. We're going to have too much norepinephrine and serotonin. That's your antidepressant action. You're going to have antimuscarinic effects, and that's going to be your dry skin, tachycardia, urinary retention, delirium. You're going to have alpha-1 receptor blockade, and that's going to be your vasodilation, hypotension. You're going to have your sodium channel blockade, and that's going to be your widened QRS, VTAC, sort of stretching out that phase 1 of the action potential. And then you're also going to have GABA receptor blockade, and that's going to be your seizures.
Yes.
What did I miss?
That's the bulk of it, especially the most relevant ones, for sure.
Nice.
Only other thing I saw was the potassium channel blockade and prolonging the QTC.
Yep. Yeah, it's typically, for tricyclics, in pharmacology in general, we make a big deal about the QT, right? There's, if you look at the list of medications that prolong the QT, it's a big list. And just about every medication that's brought to market I think they assess whether it prolongs QT or not. Fortunately, one of the things in my line of work that protects you from a prolonged QTC is tachycardia. So one of the worries with a prolonged QT is, what is the end result? Why do we care about it? Well, we care about people having torsade de pointe, and that can be a non-perfusing, unstable arrhythmia, the treatment of which is what? We overdrive pace people with prolonged QT, or someone who has an episode of torsade. We try to speed up that heart rate. And fortunately for tricyclic antidepressants, they get such profound antimuscarinic tachycardia that QT prolongation typically isn't a big deal for how we manage them. But we can tie that back into some of the other treatment modalities that will affect the QT. So in a roundabout way, it is relevant to discuss the things that affect QTC prolongation, potassium channel blockade being one of them. Hypokalemia can also be another. And we'll get to that point, so that electrolyte abnormality, when we talk about the therapeutic interventions when we manage these overdoses.
Okay, beautiful. A lot to think about here with this patient. We did give you a 14-year-old without an EKG or mental status assessment. What are you asking the outside emergency department to do before you hang up the phone? How are you triaging? And what management are you going to kind of slip in right during this first phone call?
We ask for, obviously, the fifth vital sign, glucose. We ask for an ECG, which we joke is like the sixth vital sign when we're managing just about any overdose. We want to know, what's the UTC, what's the QRS look like? That has a lot of predictive value in which direction a tricyclic overdose is going to go. And if I hear any kind of consult that says we have a patient who overdosed on amitriptyline, nortriptyline, it's one of these situations where we tend to sort of like stop whatever it is we were multitasking and really dial ourselves into, okay, we need to get into the specifics here. Tell me what those vitals were again. What was the blood pressure? Because if the patient is tachycardic, they're starting to get those antimuscarinic effects, like there's an overdose present. Okay, if someone overdosed on a tricyclic antidepressant and the vitals are normal and the patient's acting normal, it's either so early in the overdose that they haven't absorbed it and they haven't become toxic yet, or they didn't ingest it at all. Okay. Mm-hmm. And one of the interesting things about tricyclic antidepressants as a class the patients who have legitimate overdoses, they get sick pretty quickly. They tend to get sick within an hour or two. I would say they declare themselves as sick versus not sick. So if I'm called on a patient who someone says they overdosed on a tricyclic antidepressant and they're tachycardic and they're starting to act a little strange, a little altered, my level of concern is high. And we're going to do a lot of hand-holding or at least, directed therapy.
Wonderful. I have some updates on our case, some concerning things we can explore. So we have an EKG, QRS duration of 170 milliseconds. Physical exam, for especially her neurologic exam, she opens her eyes to voice but doesn't follow commands. She has some non-purposeful movements, and they're having some significant agitation and difficulty keeping her down and safe. So it's such an important point. If you don't mind reiterating to us, what are the EKG changes that you would suspect with a TCA ingestion? And if you will, I'll kind of walk us through some of the pathophysiology here.
Of course. So that sodium channel blockade that we talked about earlier is starting to rear its ugly head, and that manifests as QRS prolongation. And so depending on the age of a patient, there's a range of normal, right, for a QRS duration. And I'm going to reach back here, but for what is the age of our patient here? 14-ish?
Mm-hmm, mm-hmm.
Yes.
Okay, so we would expect the QRS to be somewhere in the 100 milliseconds or less range. And if our QRS is starting to prolong, that's going to increase the likelihood that a couple of things may occur. And those couple of things are seizures and ventricular dysrhythmias. So there's a fair amount of literature out there on this topic of what does the QRS complex predict after a tricyclic antidepressant overdose. And what we've discovered is that when the QRS is greater than 100, there is an increased risk of seizures. When the QRS is greater than 160, there's an increased risk of ventricular dysrhythmias. And when a terminal R in AVR, which is sort of a slurring of the QR, like that R wave in the QRS complex, when that is more than 3 millimeters tall, that's also indicative of what severe toxicity. And I would say severe toxicity would include ventricular dysrhythmias and or seizures. The reason that both of those are so relevant is because both those things are bad, but something interesting happens to TCA poisonings when they seize. And what happens when you have a seizure is that your pH drops, whether that's due to increased oxygen consumption and the lactate buildup from muscle contraction. But anyone who's ever checked a blood gas after a seizure, which we try to avoid, right? Because we know what it's going to show, right? It shows like a pH of 7.0, and then a couple hours later, the pH is normal again. So we know there's this precipitous drop in pH during seizures, but that's relevant to TCAs because the tricyclic antidepressant binds tighter to the sodium channel when the pH drops. That sort of exacerbates cardiac toxicity, and that's why it's so ominous if a tricyclic antidepressant overdose begins to seize, that you can kind of go down the tubes real fast. You can go from seizure to QRS prolongation, ventricular tachycardia, pulselessness, and now you're resuscitating a patient. That can happen frighteningly fast. And that is why one of the cornerstones of treatment we'll get to.
Yeah.
Let's go ahead and jump into your initial management of the unstable TCA overdose patient. So we, of course, are going ABCs, but please walk us through your mental model here.
Right. We talked about the alpha blockade and the hypotension. Everybody would have started administering crystalloid resuscitation. I think that goes without saying, but it can't be reiterated enough. There is a measure of supportive care that needs to be done for these patients. You need IVs and you resuscitate them, and you can fill up the tank, so to speak, these dilated blood vessels from the alpha blockade. But if someone has a QRS of 170 and they're getting a little agitated, we know the risk of seizures is high, which is associated with cardiac arrhythmias as well. So it may behoove us to intubate this patient for the purpose of protecting an airway. So I think it is appropriate for the patient we've described, a patient who's tachycardic, whose mental status isn't normal, who's getting antimuscarinic delirium, and has cardiac toxicity, to control this airway in case we wind up with pulselessness here in a little while. Nobody likes dealing with either of those things, but dealing with both of them at once is a bigger problem. So it is appropriate to take an airway in this situation. So I think taking an airway does two things. It obviously secures your A in ABCs, but it also offers us the ability to provide GI decontamination, some measure of it anyway. And even though it's a huge topic in and of itself, how do we recommend GI decontamination after overdose? If this overdose occurred within the last hour or two, just about every toxicologist would probably recommend administering charcoal via an orogastric tube. The contentious part would be whether you're going to do a lavage. Personally, I don't think it's that contentious. I would lavage a patient who comes in 1 or 2 hours after a stated tricyclic antidepressant overdose, who is exhibiting severe toxicity like this, who I am going to intubate. After I intubate them, I will put in a orogastric lavage tube and see if I can get some pill fragments out. And either I get them out or I don't. And then when I'm done with that procedure, I leave charcoal. That will hopefully mitigate the duration of the toxicity that these medications are going to exert on the patient. If the QRS is still prolonged, presumably it is, we haven't administered any antidote therapy, I would administer sodium bicarbonate, which can do multiple things for a patient with tricyclic antidepressant toxicity. The sodium channel blockade that we spoke about before. Number one, you're administering sodium with the sodium bicarbonate, so you're hopefully overcoming some of that sodium channel blockade by administering a sodium bolus, but also you're trying to mitigate some of that affinity of the TCA for the sodium channel blockade that occurs at lower pH. You're trying to push those TCAs off of the sodium channel and reduce some of that toxicity. One question and answer deserves the next question, which would be, well, when do we stop or how much do we give? And I think that it depends, it depends.
Oh, yeah. You've given us a lot to think about here. Zach, were you going to summarize?
I can jump in. So ABCs always do the important things first. It sounds like this is a patient that we would really have a low threshold to intubate, even in the presence of adequate gas exchange, because this patient's trajectory of illness seems like they're worsening. They're high risk for decompensation. I think that makes a whole bunch of sense. My ignorance here a little bit, I've not seen a gastric lavage, and you mentioned placing a lavage tube. Is there a special tube that I don't know of, or is this going to be done for a typical sump?
I was going to ask the same question, and I was like, everybody else probably knows this.
No, it's not something that our generations of providers, emergency providers, ICU providers are terribly familiar with. If you'd have asked all the people who taught us, the providers who are now in their 50s and 60s, I mean, they did this all the time, right? This idea of pumping someone's stomach, right? A true gastric lavage procedure is done with a flexible plastic tube that it basically just looks like a very large diameter nasogastric or orogastric tube, the one that we're familiar with that we place after intubation. But a orogastric lavage tube is typically a 36 to 46 French tube that is fenestrated on the end. And the idea is that it's big enough to pull up pill fragments. If you look at how quickly immediate release pills dissolve into mush in the stomach, it typically occurs within an hour. Okay. And that's why that window within which we would recommend or even perform a procedure like this is we know the time of ingestion was very recent. Or if a patient is vomiting pills, I mean, if they're vomiting pills, we know there are pills still in the stomach. And if the pill ID is concerning, whether it's stated tricyclic or some other serious, potentially lethal overdose, we would potentially recommend intubation for the purpose of lavage. It is not an awake procedure. And I think if you read about this topic, that's one of the big complications is obviously you don't want to perforate someone's esophagus. I would argue that's probably the worst complication. Yeah. But then, just the trauma of doing an awake lavage procedure, that's barbaric. In an era of RSI, we should be intubating patients to do that. Then that creates the big question. If a patient's not sick, right? I just took a bottle of Tricyclics. That's my chief complaint. There's no bottle, there's no witness ingestion, and the patient looks normal, and the EKG is normal. I'm probably not going to intubate just to lavage that person. Yeah. But 30 minutes later, they're starting to prolong their QRS. They're getting a little agitated. They're getting a little tacky. Probably.
Yeah.
Yeah, I think so. So that's where lavage, what a gastric lavage is. And it's not every hospital has a kit. It usually is a kit that it's done with. And a lot of emergency providers, ICU providers, you might never have seen it done because it isn't a procedure that's commonly recommended anymore. So oftentimes, if you're lucky, by the time you receive them in the ICU, it's been done, or there's hopefully a toxicologist that's willing to come in and do it for you. We try to do that at our bedside tertiary sites, and sometimes we'll even walk a provider at one of the other sites where we do remote consultation. We'll walk them through it either via Teams, something like that. It isn't particularly complicated to put a tube down someone's esophagus when an endotracheal tube is already in place. It isn't without risk, but it's something that you can be coached to do. And it can make a difference in mitigating severe toxicity. But that would be one type of GI decontamination. And then, of course, the other type, which we're all more familiar with, is activated charcoal. And you can administer that down in typical nasogastric, orogastric caliber tubing. That would be done to try to bind up whatever's left the stomach and is now in the GI, in the small bowel.
Oh, absolutely. And really both of those things, especially because in the room after like a PICU intubation resuscitation for a TCA ingestion, once the intubation's done, the other nurses who are helping leave, and then you have one nurse and you're lining and you're asking for a bicarb drip and you're asking for a midaz drip and you're doing all of these things, maybe having either the activated charcoal or the gavage kit in the room so that you can capture the time frame is important.
It is. And that's why also we're fortunate that we work in these big tertiary systems and we have toxicologists that are available to us bedside or otherwise. But a lot of smaller places, they're calling the poison center who have toxicologists to provide this advice. But sometimes it seems like a bit easier said than done when someone over the phone is just telling you what to do. Even running drills or having podcasts like this to help people prepare for these sorts of procedures. Because, I'm sure there are people listening that are like, I've never seen a lavage done and I wouldn't know where the charcoal is in the PICU, things like that.
I do appreciate the practicality of the tangent we've explored. I wanted to bring us back a little bit to the pathophysiology here. It seems like what's core to the arrhythmia part of this toxidrome is sodium channel blockade, and then this phenomenon of how acidosis might potentiate or make this blockade even worse. And it seems like the reason that sodium bicarb is chosen is because it's the best commercially available way to deliver a high concentration of sodium and also alkali. As availability comes and goes, if there for some reason there was no access to sodium bicarbonate, it seems like you can make this up with other forms of hypertonic saline and other forms of alkali. Will you maybe comment on that? And then maybe let's get to how do you titrate your sodium bicarbonate therapy? So tell us more about that.
Absolutely. You can never go wrong, right? When you're pimping your residents or your fellows, if they say, well, it depends, right? It does depend, right? So you'll never go wrong saying it depends. And I think it depends on what the response is. So, and the great thing about TCAs is that you know pretty quickly if your sodium bicarbonate is working because you can just repeat an EKG. As long as they're not in cardiac arrest, you can see pretty quickly if you are moving the needle, so to speak, on your QRS duration. So you would give 1 to 2 milliequivalents per kg IV push of sodium bicarbonate, and you would then repeat the EKG. Oftentimes you will see that QRS complex narrow, and you can either continue to bolus or you can start an infusion. That gets to the treatment parameters of, okay, well, whenever you utilize an antidote, whenever you recommend a therapy, right? Whether it's you're treating an infection or you're treating seizures or you're doing a procedure or you're offering a medical intervention, when do you stop doing it? And for sodium bicarbonate, there are some stop signs that you need to be aware of. And you can only drive the pH so high before bad things start to happen, right? We know there's a happy pH that physiology functions at. And as far as alkalemia, getting that pH into the 7.50, 7.55 range may be the sweet spot, beyond which you're probably causing problems. And then, of course, it's not just the pH that gets altered by your sodium bicarbonate, but your sodium. And I've seen multiple cases where we lost track of the sodium. We kind of took our eye off the ball and ate boluses of sodium bicarb later. The sodium is, in the 160 range. And it's like, okay, we need to consider stopping that and consider other therapy, because there are definitely times, especially in a big overdose, where you want to give more bicarb because you're moving that QRS complex back into the narrow range, but it's either widening back out quickly and you've reached those parameters and you need to do something else. So that something else would be a less toxic sodium channel blocker, which tends to make people nervous when you tell them, well, we're giving a sodium channel blocker to treat a sodium channel blocker. Duh. It doesn't sit right. And that's okay. It initially doesn't seem to make a lot of sense, but when you recognize that lidocaine can displace the tricyclic antidepressant from the sodium channel that's resulting in all that toxicity, it can mitigate some of those effects. So you can administer lidocaine to a patient if you've sort of run out of room with sodium bicarbonate therapy.
I want to emphasize, we think about in the ICU, hypertonic saline, 3% saline, having like a lot of salt, a lot of sodium content. And as I understand, sodium bicarbonate is upwards of 8% sodium bicarbonate. So that's an incredible salt load.
Yeah.
And these patients, we need to be following their electrolytes closely. And just to reiterate, it seems like the sodium goal generally don't push it past mid 150s and the pH, greater than 7.55. Are there any specifics about the lidocaine dosing in this particular instance for this toxidrome?
I would say that the dosing is typically 1 mg per kg of lidocaine. And that is, I think the max initial dose is 100 milligrams, which is useful because that is for people who have acute coronary syndrome-induced ventricular tachycardia. We administer that dose frequently, like we just push 100 milligrams of lidocaine pretty frequently. But utilizing it for drug toxicity is, yes, you can use lidocaine for lots of different kinds of sodium channel blocker toxicity. It's not limited to tricyclic antidepressant toxicity. I would say it's our second line agent for any patient who is suffering from sodium channel blockade and you've run out of room with sodium bicarbonate therapy. So your pH is 7.55 and your sodium's 155. It's time to reach for lidocaine.
And that's just for the widened QRS. Would you do that for a QRS of 110, a QRS of 180, or only if you see it?
That's a really good question, is at what point do you stop? Do you say, listen, I'm comfortable with a QRS of 120 after a tricyclic antidepressant overdose? And I think it depends on how bad it got. I don't think there's an established percent improvement. It's more about, is the patient hemodynamically stable now? So if a patient's QRS peaked at 170 milliseconds and I'm able to push it back to 130 and the patient is now stable-ish, okay, intubated. This is all relative, right? But you're intensivist, so we don't think of intubated patients, on vasopressors as being stable. But if they're not getting worse and we're on smaller doses of vasopressors to support blood pressure and whatever, there is a lactate, it's improved. I'm okay stopping with a QRS of 130. If it was as bad as 170, I've moved it in the direction I want. And now I have to ask myself, how much lidocaine do I want to give? I'm probably not going to get this person back to 90 milliseconds in a matter of hours, okay? We may just need to rely on metabolism, the patient metabolizing the overdose before that occurs. But it is something that warrants vigilant monitoring. And fortunately for tricyclics and QRS, QTC, EKG interval abnormalities, you can monitor frequently, non-invasively. You leave the 12 lead on the patient and you check an EKG every hour. And that is another great property of tricyclic antidepressants, is they really do declare themselves quickly. And a lot of this live or die after an overdose occurs within the first 24 hours of a tricyclic overdose. And if you can get them through this critical period of the overdose, a lot of them will survive.
Oh, wonderful. I want to follow up and ask, just thinking through, okay, my patient's QRS is doing X, the vasoactives are going by, I'm 755 and 155. We're starting with lidocaine boluses. Is it uncommon to end up on an infusion?
I don't know that it's uncommon to wind up on an infusion, but I think if I'm administering a lidocaine infusion, 20 to 50 mics per kg per minute, we need to start thinking ahead. If we're doing an infusion, it's because the patient's probably getting worse, and we feel like we need to keep doing that. And so if the patient continues to get worse, whether that's having periodic episodes of VTAC and pulselessness, if we've had to do a couple rounds of CPR on the patient, what next? What else can we throw at this patient? And I think some of the other options kind of depend on where you're at, what kind of hospital you work in. I think most of us know that lipid emulsion therapy is an option for some overdoses. I think that's one option. And then the other option, of course, is ECMO. I would say neither of which is a panacea for drug overdose, for salvaging a drug overdose. That you're going up on vasopressors, you've maxed out your bicarbonate and you're on a lidocaine infusion and you're still having arrhythmias. These are two viable options, but I think you both have pulled the trigger on ECMO, and it's not a panacea, right? I mean, this is a high risk, high resource intervention that we hope salvages patients, but it doesn't always do the job. But I think for overdoses that result in cardiac arrest, arrhythmias, heart failure, decreased cardiac output, and you have access to ECMO, it's a viable option. And I think the hardest question is, when do you start it? And when, unfortunately, that's a tricky question to answer. And I think the scenario you just described, where the patient may still be getting worse, or you're on multiple vasopressors and on a lidocaine infusion, it's time to consider that, because it's easier to initiate ECMO on someone who's still alive as opposed to someone who's pulseless. So that is one option, right? But then if, say, you don't have access to ECMO, you're in a smaller community site, you can administer intralipid emulsion therapy. And the idea behind that, there's lots of different theories behind it. Some people think that it provides this compartment within the blood for which to pull free tricyclic antidepressant. So it's like a lipid sink. You're like pulling the free tricyclic antidepressant that's in the body, and that in doing so provides a gradient that offsets toxicity, okay? I don't know if that is how effective that is for tricyclic antidepressants. There's plenty of case reports where patients are in VTAC arrest and they get a slug of intralipid emulsion, and all of a sudden they get ROSC, and oh my God, of course it worked, right? It's always the last thing you did to the person, if they survive, that worked. So I think it is a reasonable thing to do if you don't have the resources to initiate ECMO. And if you don't have the resources to initiate ECMO, should you be moving the patient to a place with ECMO? Should you be calling, Cohen Children's Medical Center to get them there? I would say probably. If you have a patient who has had a seizure and got intubated, and you've given some bicarb and you're starting lidocaine after a tricyclic antidepressant overdose, yeah, you should consider it. And then, of course, the logistics of transferring someone are somewhat beyond the scope of what we're talking about, but I think it's a consideration to utilize ECMO, because I think the bad things that we associate with ECMO are devascularizing a limb, massive blood transfusion, and all the problems associated with that. Typically for overdoses, if someone is going to wind up on ECMO, it's not like they're going to wind up on ECMO for weeks at a time, because overdoses are typically fairly reversible, okay? Overdose toxicity doesn't last all that long. And so getting someone through this critical 1 to 2 days of severe drug toxicity and perfusing their kidneys, perfusing their liver so that those two organs can do the heavy lifting of metabolizing the overdose and clearing it, may be all the patient needs to weather the storm and survive. I think it's a viable option, but it is performed on a case-by-case basis. And, whether it's the Poison Center or your MedTox consult service is happy to participate in that discussion and help guide it.
Reflecting on our conversation for treatment of TCA overdoses, bicarb is the cornerstone of therapy, lidocaine for refractory cases. When you get past that, we're really getting into an evidence light zone. Oh, yeah. And whether it's a lipid emulsion versus VA ECMO, and in all cases, VA ECMO is best delivered before there's multi-organ dysfunction. So if we can get this patient on pump before there's terrible AKI, before there's bad hypoxic ischemic brain injury, and we know that we could give them a chance of riding out a hopefully short run to get them, off pump and, back to a state of health, or at least a way continue to improve.
Couple follow-up questions. Now that we're thinking through the ECMO pathway, once they're on ECMO, easy to add CKRT right in or easy to plex them. What do you think about those for TCAs?
I think we don't typically reach for either of those modalities for the management of tricyclic antidepressant toxicity, usually because elimination usually isn't the problem. It's really just surviving the cardiac toxicity. So if someone winds up on pump, that would be because they have severe tricyclic toxicity. Presumably it was a large overdose. Is it wrong to put a dialysis circuit, attach it to the pump? I don't necessarily think so if the hemodynamics will tolerate it, but it probably does depend a little bit on the specific tricyclic antidepressant that was ingested as far as whether it's amenable to extracorporeal removal. Off the top of my head, I'd say I think the volume of distribution of amitriptyline, which is the most common, I think it's high. I think it's in maybe 20 liters. And that means it's not a good candidate for extracorporeal removal. So to do CRRT or HD would purely be to correct acidemia or an electrolyte derangement. So, and then as far as Plex is concerned, I'm not aware. Every time we talk about Plex in the context of drug overdose management, we tend to be disappointed with what we find, that it doesn't work very well. And we've tried it for, usually when we're trying plasmapheresis, it's because we don't have any, we're like, well, what else are we why don't we just give it a shot? And we find that it probably didn't work all that well.
Got it. This is really a fabulous discussion of the acute resuscitation, including some things we always talk about, but luckily very rarely escalate to. I have 2 questions before we move the case forward. I want to ask you about best choice of sedation, and I want to ask you about choice of vasoactives. Let's start with sedation. Can I just give them ketamine for the intubation? And then after that, do you have preferred agents that you like in these patients?
I think you should intubate with whatever you are most comfortable doing. Time is of the essence, and I think the sooner you get the airway secured, the better. In the context of tricyclic overdose airway management, I think giving a sedative and a benzodiazepine, copious amounts of benzodiazepines would be the cornerstone, both for intubation and for post-intubation sedation management. Because as we said before, if they haven't already seized, preventing a seizure with a benzodiazepine infusion, it's like you're sedating the patient to make them comfortable on the vent, and hopefully preventing the seizure, which would cause the acidemia, which would cause the cardiac toxicity from occurring. So getting them sedated with a potent, with some kind of GABA A agonist would be best. Of course, we know there are problems associated with administering heavy sedation, like hypotension, right? I think propofol is the most notorious offender for causing hypotension. So I might stay away from propofol initially and kind of move over more towards midazolam. But I think it's whatever you, the provider, the intensivist, is comfortable administering, and how well does the patient tolerate it. I don't have any problem administering propofol to a tricyclic antidepressant overdose, but I wouldn't want to do propofol in lieu of adding a second vasopressor.
Yeah, you wouldn't want to push them too high. Well, that dovetails well into my second question, which is choice of vasoactive. So we've been focusing a lot on the sodium channel blockade, putting you at risk of ventricular arrhythmias, but we also have this alpha-1 receptor blockade that's going to vasodilate you. Do you care which vasoactive we're using for our resuscitation goals?
I think that norepinephrine is usually an appropriate first vasopressor to choose. I don't know that I would just grab phenylephrine since we think of it as being a pure alpha vasopressor. That isn't to say it's necessarily wrong. If you're very comfortable with it, I suppose you could do it. But I don't want to say I'm a pragmatist, but whatever everybody in the room is comfortable giving to support blood pressure, let's just get it going here. I don't want to go to the mat over which is the best for a situation. We can debrief on that. I guess that is what we're doing now. But that's my answer, is I think for these real time sensitive issues where patients they really do these TCAs, they get sick within hours, and you can go from awake and talking to agitated and pulseless in a matter of 90 minutes. So that's how quickly these can evolve.
It's impressive.
All right. So you're saying, oh my God, stop asking vasoactive, start the norepi, please. Your patient's now been intubated and lined. Let's fast forward 48 hours. All right. Your patient's intubated, lined, managed with excellent supportive care. Your team's been using a sodium bicarb infusion to maintain her pH between 750 and 755. They did propofol sedation and we're on moderate dose norepi to maintain MAPS greater than 65. During rounds, your bedside nurse notes that she'd really love to start moving this patient forward. And she's also asking, this Foley's been in for 2 days. That's too long for Cohen Children's Medical Center. When are we getting it out? So what's the typical time course for these TCA ingestions? How fast are we expecting them to improve?
I would expect them to improve within 24 to 48 hours.
Mm-hmm.
And that's why they're so satisfying to treat, is that they are critically ill. They can have episodes of pulselessness and seizures, and then 24 hours later, it's smooth sailing, and you may be having these conversations about weaning antidotes and vasopressors. So that is not I suppose that's my experience, and I think what most people would say, a lot of these we're having these conversations 24 to 48 hours after the ingestion. That's not a hard and fast rule, right? I mean, the dose makes the poison. If someone took a 3-month supply of amitriptyline 100 milligram tabs, this is going to be a long road. And they may even, we're probably having the ECMO, how long is this person going to be on ECMO conversation, as opposed to when can we wean these things? So when can we wean vasopressors and lidocaine and sodium bicarbonate? But I would expect to have these conversations within 24 to 48 hours. And I think it's totally appropriate to try to remove a Foley. It can be tricky to determine when all these things need to occur, because urinary retention is an antimuscarinic effect. It may be the last thing to resolve. So along with the tachycardia, what's driving the tachycardia in this case as well? Is it the antimuscarinic side effects, or is it the norepinephrine? And I suppose the only way to know is start subtracting some of your interventions, your infusions, to see what susses out. While you're stopping your bicarb infusion, check an EKG, see what happens, right?
Yeah.
So you can always wait and see what happens, right? So I'm a fan of, I think bicarb is something you can just turn off. You can turn off bicarb and see what happens. Wait an hour and set your watch, set your phone, and then obviously I would say before you turn it off, check an EKG, and then obviously recheck it again in an hour.
Oh, that's great to hear. The long weans are always annoying, and
Right.
Hopefully the patient is better. What kind of bicarb rates do these kids usually end up on? 1 to 2 per kilo per hour?
Yeah, that's like the general. I think it could be more, it could be less. There are some places that we don't recommend infusions. We just do periodic boluses. We're but that can cause, obviously that creates logistical problems, and then your nursing staff doesn't like that. And it's you can watch your QRS do this. Okay, so it's really about what your ICU is most comfortable doing. A lot of toxicologists, we like the reason we like boluses is because we can wrap our heads around how much bicarb has been given. Whereas I think with the infusion, like that extra step of math, where we have a barrier to, like, we're like, how much sodium and bicarb have we given? I don't know. It's an infusion, even though it's really not that hard to calculate out. But I think that's why a lot of us just say, just give a few boluses, and then the QRS gets longer, give another bolus. But if the comfort level is within infusion and sort of holding your QRS at a certain point, you can turn it off and just see which way it goes. Once they've made it, I think that 24-hour period through the overdose, I don't think you're going to see these drastic changes in physiology that occurred in the first 6 hours of the overdose.
Oh, that's huge.
And then same with lidocaine. I would say if they were on lidocaine and bicarb, I would probably take off the lidocaine first and then the bicarb. Yeah. But I suppose if they're on lidocaine, it's probably because you had to stop giving bicarb. So they're probably not on both.
That sounds good. We didn't talk more about potassium in the QTC, but also it sounds like that might just be distracting.
You all know this better than most. When you put people on bicarb drips, you can wind up chasing potassium, right? You can wind up with this relative intravascular hypokalemia. You have intracellular shift. And then when you turn it off, things can rebound. So you don't want to go chasing a number too hard as far as hypokalemia is concerned when they're on a bicarb infusion.
We've said it already once, but this has been an incredible discussion of TCA ingestions. There's actually not a whole lot of talks in the pediatric critical care open access education world. So we really appreciate you coming on and sharing your knowledge with us.
Oh my God. I'm so happy to come on. This is what we do. We talk. So I'm happy to do it and happy to share with anyone, intensivist, nephrology, all of it.
Before I give you the final question, I just wanted to plug a couple other open access resources. There's the Tox in the Hound blog that's incredible. Lots of good talks there. And then there is a podcast that's been retired in the recent years, the Dantastic Mr. Tox and Howard Show. I learned so much from them.
Yeah, it's fantastic.
And then to give you the final word, any pearls, pitfalls, anything else you'd like to reinforce before we wrap things up?
I think for tricyclic overdoses, and perhaps almost all overdoses that come in, doing those frequent reassessments is really huge, because early in an overdose, you're absorbing whatever was ingested. So there can be a big delay in onset of toxicity, depending on the type of medication, especially delayed release, extended release, sustained release preparations. Those are like little ticking time bombs that are sitting in your GI tract waiting to cause toxicity. So I think frequent reassessments in med tox over management of overdoses can't be overstated.
Oh, absolutely. Find yourself at the bedside. Well, Dr. Josh Nogar, thank you so much for joining us today.
Thank you both. It's my pleasure to be here. Can't wait for next time.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.